All right, good evening, everyone, and welcome to the first Henry Schein webinar of 2022. Thank you for joining us tonight. My name is Adam, and I'll be your moderator. Tonight's webinar is the first of many topics we will be promoting this year relating to our Breaking Down Barriers to Care webinar series. Our mission with this series is to shine light on areas of dentistry that are overlooked by many and increase awareness to help achieve optimal oral health care, which is a critical component to achieving good oral health. Tonight, we're excited to welcome Dr. Kevin Hendler as our first speaker in the series. Dr. Hendler will be providing insights on what you need to know about treating older adult patients. Tonight's webinar is the first of two on this specific topic, with the next webinar happening later this month, and everyone registered for tonight's webinar will have access to attend that webinar as well. If during tonight's webinar you do have questions, please feel free to drop them into the Q&A section, and we'll answer them throughout the webinar, as well as at the conclusion of Dr. Hendler's presentation. All right, enough from me. Let's throw this over to Dr. Hendler. Thanks for being with us tonight.
Okay, everybody. So tonight we're going to talk about treating older adult patients, challenges and rewards. This is my only disclosure. I have no interest in any products if I talk about any. And we're going to talk about challenges and rewards of treating older adults. And the challenges are that older adults are often challenging patients, and often the treatment that you're going to provide is challenging. But on the other side, the rewards of treating older adults is huge, and we'll sort of allude to a lot of that as we go along. The objectives for tonight are to recognize the importance of the mouth in older adults, communicate with older adults, and then I'm going to put in some restorative challenges. Right. And if there's questions, I'm going to try and monitor the questions here through the question and answer. So we'll do that. Otherwise, we'll have time at the end. Okay. So I like to just start any talk, whoever I talk to, with the mouth is part of the body. And as I think as dentists, we all understand that. And this was from the Surgeon General's report back in 2000, and it was the first Surgeon General's report that dealt with oral health in America. And they basically said the terms oral health and general health should not be interpreted as separate entities. Oral health is integral to general health. And then there was a follow-up report that was supposed to come out last year, but COVID delayed it. So this just came out in December, and it was Oral Health in America, Advances and Challenges. And it was a report from the National Institutes of Health. And fortunately, they sort of concluded the same thing, that good oral health is important for overall health and well-being of individuals of all ages, their families, communities, and the nation. This is a definition by the International Dental Federation that I really like, and I sort of throw this into talks too, because as we all know as dentists, oral health is more than just the mouth. So this really sums it up, that oral health is multifaceted, includes the ability to speak, smile, smell, taste, touch, chew, swallow, convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex. And then just to sort of bring together what's going on with older adults, it is recognized concern. This is from the World Health Organization, their World Report on Aging and Health. And what they said was that one crucial and often neglected area of healthy aging is oral health. Poor oral health can have a profound bearing on general health and well-being, for example, through its influence on nutrition. Moreover, the experience of pain, problems with eating, chewing, smiling, and communicating due to missing, discolored, or damaged teeth have a major impact on functional ability in older people's daily lives. And again, I think as we as dentists understand all this, and we're going to talk about how all this ties in together. So some facts about older adults. This is from the CDC. And the first one I'll point out is that individuals who are institutionalized, like people who live in nursing homes, have increased risk for poor oral health. And these are the patients that I can see, and I can tell you that that is true. Another, almost 70% of adults over 65 have some gum disease. And then the last one I want to point out too is most older Americans take both prescription and over-the-counter drugs, and many of these medications can cause dry mouth. And we know the devastation that dry mouth can cause on individuals' oral health. This is a good thing, and you know, the other side of the coin is we know that people are maintaining teeth longer. And I've seen this firsthand. I've been practicing for a while down here in Atlanta. And I can tell you that when I first started practicing in the early 90s, there wasn't a week that went by that I wasn't working on dentures for somebody. And in the past couple of years, the number of complete sets of dentures that I'm doing has drastically decreased to about maybe a handful in the course of a year. Now, I am doing a lot of individual dentures, but people coming in needing a complete set of dentures has really decreased. So we know that, and here the statistic sort of bears it out, that 75% of those aged 65 to 74, that they are more likely to have teeth. The other thing, so it's a good thing in that people are keeping teeth longer, but the downside is that as people get older, a lot of times they become more dependent. So they need somebody to take care of them. They can't do it themselves. And if they have more teeth, and I can tell you that oral hygiene is not on top of the list for people that are providing care for others, it just gets neglected often. So the teeth suffer, the oral health hygiene suffers, the oral health suffers, and the combination of having individuals that are more dependent, have a lot of teeth that are at high risk, is one of the reasons that the dentistry is more challenging. This is my definition of geriatric dentistry, and it's a branch of dentistry that provides oral care services for older adults with physical, medical, developmental, or cognitive conditions. And here's the important part, which limit their ability to receive routine dental care. So a lot of these patients are not going to walk into the office, sit down in the chair, you say open your mouth, they open their mouth, and everything goes along fine. They're more challenging to treat, but again, more rewarding when you're successful. And then a dental geriatrician. So this sort of came from a conversation that a number of us who were part of the American Society for Geriatric Dentistry had. And we were just sitting around in a meeting one year and decided, we were usually referred to as geriatric dentists. And we decided that wasn't the best title because, you know, when I was younger, I would go in and they'd see I was a geriatric dentist. They go, you don't look that old. So we decided that we should have a different name. And we sort of took it from the medical model where physicians that treat older adults are geriatricians. So we decided to call ourselves dental geriatricians. And if you want to be a dental geriatrician, that doesn't have to be your specialty, but you need to be accessible to all patients with limited mobility. You should promote oral health for older adults any chance you get. If you have the opportunity to tell people how important it is that older adults have access to healthcare and that their oral health is maintained, that's a really good thing. You want to understand the impact of oral health on overall health, and we'll talk a little bit about that. Promote oral health, I said that, and like challenging patients and creative solutions. And that's one of the things that really brought me into it is I like coming up with solutions for situations that are not what they taught us in dental school, but I need to be able to treat the person and come up with a good solution. And then for any dentist, you need to practice prevention. These are just some reference books. Older adults have medical complications. They're on a lot of medications. And I will always go back to refer to references just because I don't always remember everything. And these are just a couple that are really good. So one thing is if you want to treat older adults, then your office needs to be accessible. And you need to have good lighting. You also don't want a lot of rugs on the floor because they're trip hazards. So this was just part of my office. And we have low pile carpet here. The rest is simulated hardwood flooring. And you can see the chairs have a firm seat back and there's armrests to make it easier to get in and out of. Oftentimes you'll go into offices and you'll have those really comfortable couches with the big cushions and you fall in and you sink in. And yes, they're really comfortable, but if you're an older adult, it's often really hard, if not impossible, to get out of those chairs. So you want to have the chair higher with arms so they can get out. Also notice that there's space for wheelchairs in our waiting area so that when people come in a wheelchair, there's a place to park the chair next to somebody who brought them in. I like dental chair, and that, what I said previously, is things that you can do to your office. It's not a big deal to put in a couple of chairs that are easy to get in and out of. The dental chair itself is a different story because, you know, your office may already be set up. But when we set ours up, I like dental chairs with arms. We have patients that have difficulty maintaining themselves sitting up in a sitting up position. They'll fall off to the side, and it's much harder to fall out of a chair when there's big arms on the side. Now, having said that, we did actually have a patient who managed to slip out of the chair anyway. But a lot of times patients will be leaning off to one side, and I just feel more secure that they'll stay in. There's also space for a wheelchair. So if a person comes in a wheelchair, then we can pull the wheelchair next to the dental chair and transfer them. And as far as transferring goes, what we do now is I always ask whoever brought the patient in if they can do the transfer, because usually if they brought the patient in, they've gotten the patient out of the car into the wheelchair and first in, from the wheelchair into the car. So they're good at transferring the patient, and then I don't have to worry about it or have my staff do it. So I'll always ask whoever comes with them, can you transfer the patient in the dental chair? Now there are patients that will come with a transport service that are not transferable. And in my office, we have a wheelchair lift, and this you need a lot of space and and it's an expensive piece of equipment. But this, because we treat a number of patients in wheelchairs, this really makes the office accessible and a lot easier on me. So basically you can wheel the chair into that, and then you can recline the wheelchair so that I don't have to be leaning over forward and working on individuals. So it just makes it much easier to treat the person. Health literacy is also important, and oftentimes we don't think about how important this is. So older adults are at increased risk of low health literacy. Reading ability scores decline considerably after age 55. So all of us who are older 55, here's some news for us. Many older adults have experienced varying degrees of auditory, visual, or cognition losses that affect health literacy levels. Furthermore, differences in generational cultures can also impact communication. And the importance is that if you tell somebody, you want them to understand what you're saying. So it's important to speak at a level that's not, when I was writing articles for a website, they said, write the article at a 6th grade level. And I thought that was low, but you want to make sure that people understand what you're saying. And I had a patient that came in one time, and I thought this was great. She pointed out to me the importance of health literacy, and that sometimes you explain it and the patient nods and says they really understand, but they may not. And this woman went in to see her physician, and it was an ophthalmologist, and he said, I want you to take these vitamins for your eyes. And we all understand that you take vitamins orally. And she knew that too, but she wanted to make the point. So she said to her physician, she said, I have 2 eyes. Should I break this in half and put half in each eye? And I thought that really summed up the idea of health literacy. So you can ask people to repeat back what you said, but it's important that they understand what you're saying. There are lots of communication challenges, and I can tell you that successfully communicating can determine the success of the treatment. If you don't understand what the patient wants and the patient doesn't understand what you're trying to tell them or what you can provide, then you can be the best dentist clinically, but it still may be an issue that the treatment's not successful because there's not the understanding between it. So first, you want to know, what are the patient's desires? What's the chief complaint? Why did they come into the office? And along with that, you want to set expectations. So in our office, we do not do prophies on the first visit. And the main reason is that we're dealing with older adults that usually have complex medical histories. They have long lists of medications, and the dentistry is not always straightforward. Oftentimes they come in with active disease in their mouth, and starting with a prophy may not be the best bet. Plus, I really need to know about the medical status. So we tell the patients on the phone that that's what the situation is. Another situation is I had an individual come in, and he came in with his wife who had late stage dementia, and she had some decay in her front teeth. And he came in with the expectations that he wanted a full mouth rehab on his wife. And that was not realistic because she couldn't tolerate the treatment, and that was the treatment that was not indicated. So, we discussed all this. The care provider that he brought understood all this. And we had a long discussion to make sure that he knew what was realistic as far as the expectations and what the treatment outcomes could be. You need to have a medical history. This goes for all patients, and especially with older adults. What we like to do, and I can tell you that you want to attack this ahead of time, because otherwise it can chew up easily 15 to 30 minutes in your office while they're filling out a medical history form. So we send the form to the patient before the first visit. When they call up and schedule the appointment, either we could mail it to them or we can email it to them. And this way they have time to get everything they need, to get their medical records, to get their list of medications. The other thing we sometimes recommend is that they just bring in all their medications in a bag, and then I can sort through everything, see exactly what they're taking. And from their medications, you can get a good idea of what their medical history is too. Now, I have a big advantage being in a big medical complex that I have access to electronic medical records. And a lot of the patients that I see are already Emory patients, and somebody else has sorted through all the medical history. So I can just pull up the record. I can see what their medications are. I can see what their medical problems are. And that's a huge benefit. But you don't always have that. And sometimes you're going to have questions about what the medical history is. And you're going to need to talk to their physician because you don't want to treat someone without really knowing what's going on. So what I want to point out here is that you don't want to call the physician and say, can I have clearance to treat this patient? Because you're going to get answers that you don't want. You want to have a specific question. And an example is the patient comes in and says, I had heart surgery a couple of years ago. Well, what did they do for you? I'm not sure. Well, that's important for us to know. Did they have a valve replaced? Did they have a bypass? Did they have a stent placed? We need to know that. So I may need to call the physician or contact the physician and say, hey, Mrs. Jones gave me a history of a heart surgery. What was done? I don't ask the physician, is it okay to treat her? Because as dentists, we're the ones should be making that decision, and we know what the answer is to that. We just need to know the specific concerns. If you say, is it okay to treat this patient? And the dentist and the physician says, no, I have concerns about you providing care, then you're stuck. So don't ask for clearance, ask for a specific question. And then also know that knowing the medical status, that can influence the treatment decisions. When a patient comes in, I like to bring them back to the chair. I like to sit in front of them and make eye contact. So I'm not speaking down to them. I'm speaking directly to them. I introduce myself and I say, what brings you here? What's your concern? Now, I hear the concern, and oftentimes the chief complaint is not the most pressing problem. So what I like to do is direct the person. My first visit is, and we told them it's going to be a comprehensive exam, but I like to lead them in that direction, that we're going to do an exam and x-rays, and we'll see what that concern is and how it fits into everything else. You want to speak directly to the patient, and I say that even if they have dementia. I think it's just a sign of respect. Plus, you don't know what they understand. And it's an uncomfortable, almost embarrassing situation when the person sitting in the chair, the child or the care provider standing behind them, and you're basically speaking past the person to the care provider. And the patient says to you, hey, talk to me, I'm the patient here. So you want to treat them. The other person in the room will hear what you're saying and they can chime in if they have to. Also, listen to the patient. It's just a sign of respect. Now, if they have dementia, sometimes the babbling goes on and you're going to have to interrupt that. But I do like to listen to the patient, at least for a little bit in the beginning. The other thing to remember is that not all older adults are hard of hearing. And, I'll still get stuck with this because I'll be in one room where they are hard of hearing. I'll be speaking loudly. I'll come in. I won't tone my voice down. And the patient says, hey, I hear you fine. I'm not hard of hearing. Use a clear voice. If you shout, you actually raise your voice and it's harder to understand. So if you need to speak louder, but keep the same tone. Don't shout because the voice becomes higher pitched and it's harder to understand. I like to address everybody with the title. Again, it's a sign of respect. If they say, hey, just call me Joe, that's fine. Don't talk down to the patient. And when I say don't talk down to the patient, I'm talking about the baby talk that we hear. Unfortunately, not as much. But when sometimes people speak with older adults, they use that baby talk, and it's just completely disrespectful. This is an adult you're talking to, and I think they should be treated with respect. I think there's no place for the baby talk. I will ask who completed the medical history because that may be the person I want to speak directly to. And if that's the case, when I'm asking questions, I will say to the patient, your son filled out the medical history, so I'm just going to speak with them for a little while, just so it doesn't look like I'm ignoring the patient. Have a family member present, especially if there's dementia, because you want to get accurate information and you want accurate what you're saying to be understood as well. Tell the patient what you're going to do. I will address the patient, and before I start anything, I will tell them what I'm going to do, including I'm going to recline the chair now. You don't want to surprise people, especially if they have dementia, because your appointment can end rather quickly. Use touch and a smile. If you smile through the appointment, you get a really good response. People pick up on that, and if they sense that there's a friendly environment, I find that people will cooperate much better. And then touch too. Again, when I'm reclining the chair, I'll place my hand on their shoulder to sort of guide the patient back so that they're not startled and want to jump out of the chair. If you want somebody to remember what you're saying, have written instructions. And that's just the best thing. So the things that are important to us is written down. I will review them, and then I will hand them the instructions so that they have them when they go home. And realize that some things are going to take a little more time. And that's important, but if you spend a little more time, the payoff is huge. You really get much better outcomes, and I think it just works out really well. And then I'll repeat this over just because I do, but respect and dignity. I can't stress that enough when you're treating individuals, definitely with older adults, and I would say any patient that you're treating, treat them with respect and treat them with dignity. So for patients with dementia, they may not understand the situation that they're in, but if they trust you, if they trust the caregiver that's with them, then they often cooperate and you can get things done. And this is just maintaining a calm environment and, again, effectively communicating. I can tell you that treating individuals with dementia can be really frustrating. They don't come in and sit down. Sometimes it takes us a while to get them into the chair. There have been instances where I've gone out to the parking lot to look at a patient because the care provider couldn't get the individual out of the car. But when you get them in there and you get in their mouth, it's really rewarding. If you speak to the individuals, when you speak to the individuals, you want to use short sentences and simple words and give them time to respond. Sometimes it takes a little longer. If you need to repeat a question, use the same words, because otherwise it becomes a different question. I will also stress again, nonverbal communication. So lots of smiling, just keep a friendly environment, and then remove the fear of the unknown. Explain everything you're doing. All right, so I saw a question pop up. Are there any guidelines for transferring patients? Yeah, there are. I don't know about specific guidelines because you're going to be responsible. And that's why I say, if there's a care provider that comes with them, then that's your best bet, because if they can transfer the patient, then you don't have to worry about doing it. There are really good ways to transfer patients, and there are videos and things to do that. We usually, if we're going to do it, we like to do 2 people just because it's safer that way. But there are sliding boards. There's 1 person transfers. But again, if there's a care provider, they're the person that oftentimes will stay in the room with the individual. They'll do the transferring, and it works out really well that way. Okay. There are also, so we talked about some of the communication challenges. There are also restorative challenges. And why is it restored? Why is it challenging? Well, some of it you probably know. And one of the things is that the patient comes in and doesn't need any treatment. A family member or a care provider brings the person in because they knows their problem, and the patient says, I don't have any problems and I don't want you to do anything. And you need to, especially when there's significant issues like abscesses, infections, you need to somehow convince the person, yes, they do need to be treated. A lot of older adults have complex medical conditions, and it's not just a matter of jumping right in and treating the individual. They're on multiple medications. These can include anticoagulants or blood thinners, anti-resorptive agents, and just a host of other drugs that can have side effects, and we need to know what's going on. Are they going to interact with things that we give? So it makes it complicated to manage the patient. As we mentioned before, cognitive impairment is definitely a challenge from a lot of standpoints. You need to get into the patient's mouth. You need them to have to trust you so that you can do this. The individual may come in and there's just extensive dental disease, and you're saying, hey, where do I start? And what do they want done? What are their expectations for what's doing and what they think can be treated? The other is, and I get this, I used to get it more, not so much now, is I'm too old for treatment. And I always liked that one because, my response would always be, well, do you know how much longer you have left? Because the answer to that is no. And if they do, then yes, maybe you want to tailor your treatment to them. But I had my oldest patient was 110 years old, and she still had teeth. And if she came in when she was 70 years old and said, you know what, I don't want to do anything, I'm just too old for that, that's 40 years she had to put up with that. So you don't know how much longer you have left. And my feeling is that you should do what you want to do to make you comfortable and make you happy. And then there's financial concerns, which is a big problem. In the state of Georgia, Medicaid does not cover routine dental care for older adults. It covers exams, x-rays, and extractions. I know some states don't cover anything, so there's no preventive services, and some individuals just can't cover the dental care. So that's something that we often have to work through also. I say sometimes you need to get the patient and the caregiver to accept the treatment that's indicated. Oral health can impact general health. Okay, we understand that. The simple thing is if somebody comes in with an abscessed tooth, they can have systemic disease. They could be swollen, they could be febrile, they can be sick, and sometimes significantly, especially in older adults. And we also know that general health can impact oral health. And one example of that, or two examples, one is patients with dementia. At some point, you forget to brush your teeth. Okay, somebody could remind you, but you may also forget how to brush your teeth, and somebody needs to do that for you. And that goes back to what I said about dependency. The other is a situation like rheumatoid arthritis, where your hands may be so twisted that you can't grasp a toothbrush. And again, you need somebody else to provide the oral care for yourself. The other thing I want to point out is that if the spouse is a caregiver, the general health of the patient often impacts the oral health of the spouse who's the caregiver, because what happens is they're so focused on taking care of their husband or their wife, they end up neglecting themselves. And I can tell you that there have been numerous occasions where a spouse will be taking care of their other spouse for several years. And then after that spouse dies, the caregiver comes in to see me, and their mouth, it's been neglected for years, and it's really hard to play catch up on that. So, a lot of times I'll tell people, make sure you still take care of yourself, even though you're taking care of your husband. Dental care can impact quality of life. Yeah, we know that people are willing to spend a lot of money for aesthetic dentistry. And another example is, I bring this up later, but I'm going to mention it now, is I had a patient who was in hospice. And she was embarrassed by the way her teeth looked, and she didn't want anybody to come visit her. And that was tough. Hospice, she had less than 6 months to live. And she was basically isolating herself from family and friends that wanted to come say goodbye. Well, she ended up in my office, told me what the problem was, and she had numerous broken teeth. And what I ended up doing is I just ground everything down, took an impression, made a denture on top of everything, and sent her back. And that was a quick way. And I found out a couple of weeks later that they actually kicked her out of hospice because she started to gain weight and she was doing much better. It was short-lived because she still died within the year, but she died with family and friends around her, which made a much nicer situation for everyone involved. Periodontal disease and dental caries are infections, and we speak about that. People understand infections, especially care providers. If you say brush the teeth, it's like, oh, I don't have time for that. If you say, you know what, there's infection in the mouth, we need to treat the infection, you get a much better response. And having said all that, sometimes the answer to necessary treatment is still no. I had a patient who had numerous draining fistulas. We tried everything we could. His daughter tried everything, and he just refused to have anything treated. So you do the best you can, but sometimes you still can't get treatment accepted. Getting the person to accept needed treatment, I will discuss things that maybe impact the person. So one is nutrition. We need to eat. And that's easy to explain to patients. You need to eat. And it matters what you eat. If you're just eating, if you have a poor dentition and you're choosing softer foods, they tend to be higher in carbohydrates and lower in protein, so you're impacting your nutritional status. The other thing in long-term care facilities, eating nutrition is a social activity. So if you're embarrassed by your teeth or how long it takes you to eat, you may tend not to go on the outing to the restaurant. You may not go down to the dining hall, and social isolation can lead to depression. Respiratory disease is another thing. We know that poor oral health can lead to pneumonia, and pneumonia in older adults is a significant issue. Older adults die from pneumonia. Kids tend to get better, but there could be long-term implications. They could spend a lot of time in the hospital, ICU, rehab, so there could be problems after. So they understand if they had pneumonia, and you can explain, hey, you've got all this infection in your mouth and I don't want you getting sicker, so it's important that we treat this. Diabetes, I'm sure you're aware of a lot of the studies that find the association between diabetes and periodontal disease, and how treating the periodontal disease can improve the glycemic control and vice versa. So diabetic patients, I'll raise that issue with them. Cardiovascular disease, same thing. There's a lot of studies finding an association between heart attacks and strokes and periodontal disease. So it's good talking points, especially if they have periodontal disease. That a patient came in with a recent stroke and he had really bad periodontal disease. So we talked about, hey, you know, there might have been a connection with this. And then depression, frailty, dementia, a couple more studies. This one, and a lot of this is new stuff. So this is 2017, oral health and the incident depressive symptoms, a longitudinal study. There was in 2018, the influence of poor oral health on physical frailty. In 2018, chronic application of a periodontal pathogen results in brain inflammation, neurodegeneration, amyloid beta production. So there's definitely connections. I bring up frailty because frailty is a significant issue in older adults. Frailty is actually a geriatric syndrome. And what we know about frailty are individuals with frailty just have poor outcomes with whatever you do. If they need surgery, if they get sick, they have a tougher time recovering. And so here was a study looking at an association between oral health and frailty. And they said that significant longitudinal associations between oral health indicators and frailty highlight the importance of oral health as a predictor of frailty. So if we can influence frailty by improving oral health, it's going to have really broad influence on just overall health in the individual and just outcomes from treatment that they have going forward. This, I think, has now become my favorite study, assessing the role of Porphyromonas gingivalis. And one of the things they said was chronic periodontitis increases the risk of getting Alzheimer's disease. And what they did in this study is they gave mice Porphyromonas gingivalis orally. And what they found, and this is just one of the bugs that causes periodontal disease. And what they found was that when they looked at the brains of these mice, they saw the same changes that you would see classically in Alzheimer's disease. So they saw the neurofibrillary tangles and the amyloid plaques. And what they concluded was maintaining a healthy mouth and managing periodontal disease with good oral hygiene and routine dental care throughout life is likely to reduce the unnecessary burden of Alzheimer's. And nobody wants Alzheimer's disease. And if you could say, hey, you know, this is one way you might decrease your risk of getting Alzheimer's disease, it might be a really good motivation for treatment and for flossing. Risk assessment is just how we deal with older adults. You want to know, you know, what you're getting into here. And I think it's just a good way to approach how you're going to develop a treatment plan. Is there a lot of decay when they come in for the first visit? Is their oral hygiene poor? Do they have a lot of exposed root surfaces? Do they come in for routine care and they have decay every time they come in? These are patients that are going to be really high risk. And you need to factor that in when you're thinking about, hey, how I want to treat the person, how much prevention I want to do. And it's going to influence your treatment decisions. This was just an individual that came in one day, and you can see the screen, and there is a lot of root decay. And, you know, this was a restorative challenge. It was a patient challenge because she was frail. And she knew what she wanted to have done. And it was a tough case. And I'm going to speak about that next time. Alzheimer's disease, the risk assessment and things you want to know before you treat somebody with Alzheimer's, it's a progressive disease. The disease gets worse, we know that, and you want to think about what the future is going to be. Oftentimes, it's going to be more difficult to treat people with Alzheimer's disease. Now, that's not 100%. I've had patients that went through a phase where they were really combative, really difficult, and then as the disease progressed, they seemed to really mellow out and became easier to treat. But as a general rule, you want to fix stuff early on in the disease when they're still able to cooperate. You want to do simple stuff. You want to think that if I have to repair this, like, am I going to be able to repair this going forward? And then maintain teeth if possible. This is definitely open to discussion. And I've gotten into discussion because I'll have patients that where the family will come in and say, I want you just to take out all of my mom's teeth because nobody's going to brush them. And I'm reluctant to do that because some people don't get dental disease. I see patients where they come in and you can't see the teeth because nobody's doing any oral hygiene. And my hygienist cleans them up and it looks like they've been brushing and flossing every day. So there's not really a good indication. The other thing is that I don't know what's really going inside their head. And are they aware of their teeth? Can they eat with their teeth now? I don't want to cause more problems by just taking teeth out. So it's a discussion that I have, but I can tell you personally, I like to maintain teeth if I can. You want to avoid complex treatment. As I mentioned before, you don't want to do stuff that if it fails, you're going to have a really hard time correcting the situation. Use what you have to avoid big changes. If there's a partial, can you modify it? Decrease excess activity, background noise. And then this works really well for me. If I have an individual with late stage dementia and I'm trying to do care, and even any stage dementia, I find that if I'm speaking throughout the procedure, it often is enough for me to get things done. It can be a distraction to the patient, and it doesn't have to be a true conversation, but I'll have a lot of discussions with my dental assistant, and we'll just talk about anything. And if things get tough, I'll start to sing. Now, I'm not a good singer, but again, there are studies that show that individuals with Alzheimer's disease and dementia respond to singing. So I can sing, again, doesn't matter what song, it doesn't matter that I'm not a good singer, but oftentimes if I'm really having a difficult time, I'll just start singing or humming, and that tends to distract the person enough where I can get things done. Having a family member present, there's a question mark there. Sometimes it's good, sometimes it's bad. If there's a good relationship between that family member and the patient, then oftentimes it's beneficial because they will have a calming effect. But there are some family situations and family dynamics where there's a lot of tension between the two individuals. And in that case, the patient's going to sense that and cooperation may be harder. And in situations like that, I'm going to ask the family member not to be present because it's going to be more difficult for me to get treatment done. When I have a care provider, and whoever is, even if it's a family member, I'm always explaining how important it is that oral health is important, and that oral hygiene needs to be done every single day, and do the best you can. And prevention, that's just what dentists do. So this was an individual who came in with late stage dementia, and they were in pain, and you can see why. Their tongue was being lacerated by the teeth. I was kind of amazed I got this picture. So the immediate thing is what am I going to do? And in this case, it was a matter, I had very limited time. I was able to smooth the points off on that, and that became the definitive treatment. The tongue healed up, there was no more issues, and we were good. You want your patients to be comfortable, just because it's nice to be comfortable. So on this chair, there's some neck pillows here. We have different shapes and sizes. Not everybody can get in a chair and rest their head back. If they have neck issues, if they have osteoporosis, rheumatoid arthritis, they can be bent in crazy positions. You want them to be comfortable. So we have an assortment of pillows. We give everybody these disposable sunglasses that just pop over their eyes to keep the light out. Lubricant on the lips. Now that's pretty much after we're done. I don't want Vaseline on the lips when I'm going in to treat, but we do have blankets, earphones. I haven't had much success with those, but some people say they work really well as a distraction. I think I'll just leave it at that, but it's an option. You want to protect your fingers. There's different ways to do that. There are products you can buy. And then what we do is we just take a bunch of tongue blades and just wrap them up. And I do pride myself that I still have all 10 of my fingers after over 30 years of practicing. So that's good. So here's a restorative challenge, maybe. Person comes in, they have a broken tooth, the crown popped out, and normal, healthy individual, you'd look at it and say, okay, we know what to do. We could do endo, post-core crown, maybe an implant, maybe a fixed bridge, RPD. Not very challenging, right? Well, what happens if the same person comes in, but now they have late stage dementia? So they're not very cooperative. You have limited time in the chair and they want their front tooth back. Now, all of a sudden, this becomes a challenging situation. So what do? What's quick and fast? And what I found that works really well is I will just put a bunch of pins in the tooth, clean out the inside of the crown, the core that's broken off in there, etch it, fill it up with a core buildup material, squish it on, rebond the tooth, and this works. Now, patient selection is important. You're not going to do this on Bruxers, but on a lot of the patients that I have that don't bite that hard, or if the tooth is not an occlusion, this works really well, and it's a quick way to do it. And again, expectations, I tell the individual, I tell the patient, this is what we're going to do. There's a chance it may not work, but hopefully this will work, or the care provider. Similar situation with a bridge abutment. So this was a tooth that was loose on one of the abutments, couldn't get the bridge off. I sectioned the bridge, and you can sort of see there a little bit, took off, and you can see this abutment is completely decayed. So after I excavated the decay, this is what's left. And same thing, put a bunch of pins in, and you can get away with this in older adults because the pulps shrink. So you can put a lot of pins in there, filled it up with core buildup material, bonded where I sectioned the bridge together with porcelain repair, and this worked. This patient kept this for several years until they died. So, just think of things that you can do, which is what I like about it. Again, we mentioned before, if somebody has an existing partial, I'm always looking for the existing partial. They had an existing partial, they came in and broken teeth, and very simple, modify the partial and real easy treatment. Another restorative challenge, this was a woman who came in. She was 99 years old, and she was pretty frail. And she had been to a previous dentist, and her chief complaint was that her upper partial didn't fit. And she had been to another dentist, and he basically said, not much I can do, you just have to live with it. And she didn't like that answer, so she came to my office. And you can see why the partial didn't fit. I mean, the abutments were broken off, and the clasps on the partial were broken off, and it was no good. Now, she had some decay in some of the teeth, and you can see on the other screen where there's decay and the abutments that are broken off. She didn't want to get into a whole lot of treatment, and that was the thought was, hey, we can fix this up. We can put some implants in. We can do fixed bridge. That wasn't what she wanted. She just wanted her partial back. And what is the simple solution here was to modify the partial. So I did a couple of fillings in the teeth that had decay, and then added some clasps on, replaced the missing teeth. And now she has a retentive partial that improved the aesthetics, and she was very happy, and the problem was solved. So helpful hints, just as we went over before, treat with respect and dignity. I can't stress that enough. It's just so important to treat all patients with dignity and respect. Make the patient comfortable. There's a bunch of ways to do that, but if they're not comfortable in the chair, it's hard to sit still. So, and it's going to be much more difficult to treat them. Address the chief complaint. Now, as I mentioned before, my first visit is an exam and x-rays. I don't do a prophy. But you still want to address the chief complaint because it's just respectful. You're telling the patient, I heard what you said, and this is what we're going to do about it. But again, a lot of times that's not the main issue. If their complaint is, hey, I chipped my incisor, and you look in and you see there's draining fistulas and broken teeth and periodontal disease, then that's going to become the more important thing to treat. Keep track of your fingers. Give options. There are always treatment options. There's not just one solution in dentistry. We can always come up with things. And don't prejudge somebody. You know, we try not to do that. And sometimes we do anyway. I had a patient come in and he was just, you know, he had food on his shirt. His hair wasn't combed. He just looked really messy. He had a broken tooth. And you start thinking in your head, oh, he probably doesn't care. Well, he did care. There were reasons why he was dirty that day. And we discussed what the options were. And he said, I want a gold crown on that tooth because that's what I want. And I think that's the best. So treatment should be realistic and practical. You know, like we mentioned before, it's got to be something that you can do, something that could be maintained. Ideal dentistry, you know, the best that we have to offer as dentists is not always the best that we can offer that patient at that time. Don't let age influence treatment. And sometimes we think, oh, you know, they're too old for treatment. That's up to the patient if they want to decide they're too old. But I will always give them treatment options. I have patients in their 80s that say, hey, I want implants. I don't want anything removable. So give everybody the option and let them decide what you want. Medical status, on the other hand, can influence treatment. You know, there are certain conditions where you may change your treatment plan. So that goes back to what we said in the beginning. It's just really important to understand what their medical status is and then let it influence. And quality of life can override pretty much everything, especially end of life. So I mentioned the person who was in hospice, but there have been other patients that, you know, we make decisions. I do a lot of palliative dental care and make decisions based on just comfort. And that's what the person wants. And it's, you know, we're not going to take the tooth out. We're going to leave it. We're not going to restore that. We're just going to try and make you comfortable. So here's another restorative challenge. This was an individual who was 99 years old, and she was a dental phobic. She was also very vain, and she was cognitively intact. She knew what she wanted, and she wanted teeth. And so what do you do in a situation like this? Well, ideally, these are all broken off roots. We would take those out, let her heal, and make her a denture. We could talk about implants. She wouldn't let me do anything. She actually came in, some of the teeth would be symptomatic, and she would refuse. And I would try and come up with all these plans with her care provider to figure out ways where we can do something. And she was so sharp, she wouldn't let anything. I could prescribe her antibiotics and that was it. So she was in charge of her life. She was in charge of the situation. So I needed to come up with something that was going to satisfy her chief complaint, make her happy. And what I ended up doing is similar to the hospice patient, is I took an impression, I smoothed off the sharp edges, took an impression and built the full denture over what was there. And she was very happy with the results and happy patient. Okay, so I'm going to leave it there. And I could tell you part 2, we're going to talk about more restorative challenges. I'm going to talk about dry mouth and root caries, which are the biggest problems that I see as a dentist treating older adults. So on that, let me go pull up the question and answer. I saw a couple more pop up here. Okay, so do you ever prescribe palliative care, and what does that look like? I treat patients who have an average lifespan of 2.7 years. Yes, we do. I mean, prescribe palliative care. Yeah, and I will do it. And again, it's just whatever it takes to make the person comfortable. And a lot of times it's smoothing off a broken tooth that's irritating the gum, opening. Sometimes if there's an embrasure space that is too tight and stuff's getting stuck and it's hard to clean out, sometimes I'll just open it up completely. If there's a filling in there, just grind it away. So it's really, there's not anything hard and fast, but it's what's going to make the person comfortable. And I don't think that there's a right or a wrong as long as the person's comfortable. I have a very hard time extracting teeth on older adults when alveolar bone is very brittle. You know, you just have to be careful with it. Yeah, sometimes you lose a buccal plate once in a while, but it really, don't go in there and just yank those out. And on the other side of the coin, the bone sometimes makes it easier to get the tooth out as opposed to individuals with really dense bone. But I will spend time, I'll spend time elevating the tooth, really working on it to get the tooth loose before I put a forceps on it, and in order to get it out and try and be cognizant. But again, sometimes it you know, things happen, and then just, you know, sew it down and they'll heal. What is my favorite of restorative material for root caries? All right, so here's, should I answer this question? This is going to be discussed at the next seminar. I will tell you, just because I don't want to, well, I'll tell you I really like glass ionomer, and I'll leave it at that. Do you ever do endo on 90-plus-year-olds? I would, if it was indicated. But having said that, what I found to be really easy is refer, because endo on older adults sometimes is really difficult. The canals are calcified, but if there's a tooth where there's a situation where the tooth needs endo, again, I'm not going to take the agent. If I think that's the best treatment and that's what the individual wants, then usually in a situation like that, I'll refer them to an endodontist, just because I know the endo is going to be really complicated because it's hard to see the canals. Broken tooth at or below gingival margins, do you extract or leave alone and see if it develops problems in the future? That depends. That is a really good question, and I'm sort of faced with that a lot. And there's not really, you know, if there's active infection, if there's apical pathology, if there's a fistula involved, then I'm going to want to get it out of there. If it's been endo treated and you know, and it's not bothering the person, and again, looking at what their medical status is, if they can tolerate the extraction, and I think it's going to be a simple extraction, then yeah, I'll go for it. But if I think it's going to be difficult because of medical situation, or because they're going to be an uncooperative patient and it's asymptomatic, then a lot of times I'll just try and smooth it off and leave it alone, and then just hope it doesn't develop a problem. Because you don't want to, you know, we certainly don't want to put older adults to sleep to do dental care. It's just not, you know, there's too many complications with that. All right, let's see there's stuff in the chat too. I don't know.
Lots of stuff I'm posting. I think you got through all the questions. There it is, January 27th, 8 p.m. Eastern. I also posted the registration link in the chat in case if anyone wants to get a jump start and register for that tonight. We do have a couple minutes left. If anyone does have any last questions, I'll leave it open for about 30 seconds or so. And if not, we'll wrap up a smidge early.
And also, I will tell you that you can get my email. If anybody has questions, you can email me. Should I can put my email address in the chat here, I guess.
Yep, go for it.
Let's see.
Really great question that came in. How did you get into geriatric dentistry?
That is a great question. Hendler.edu. Okay, so there's my email address. If anybody has questions, feel free to email me. So I was a junior in college with no major and no career. I was actually taking pre-med classes. And I went home and spoke and decided to be a math major because I knew I can graduate. And I had a neighbor who was in dental school that I grew up with, and he suggested it to me. He said, have you ever, thought about being a dentist? And I hadn't. And what really tipped me off is that summer, I volunteered in a dental clinic. It just happened to be one of the first dental clinics in a nursing home. And the dental director there was considered one of the fathers of geriatric dentistry. He was originally trained as a pediatric dentistry, and his name was Dr. Saul Kamen. And he was my main motivation. Working with him, volunteering in his clinic, he inspired me that, yes, I want to be a dentist and I want to treat older adults. And to be honest, I can tell you that I've had no regrets. It's been an extremely, well, hopefully all of you in dentistry have appreciated how rewarding dentistry is in general. And I could say just treating older adults has added an extra layer of reward for me. It's just so wonderful when patients come in that couldn't be treated or couldn't have access to care because of medical issues or because of cognitive impairment, and we're able to get treatment for them. So that's how I got into it, and still enjoy doing it today.
Let's see a couple more in here for you.
Okay.
Do you use silver diamond fluoride in any of your cases?
I'm going to say yes, but I'm going to speak more about that next time.
What a teaser. Looks like there might be some comments for you in the Q&A as well.
I'm looking here. I wish the PCPs we have contracted were as understanding about the situation as you are. Yeah, I go back to communication. I mean, I have a good relationship with the physicians that I work with, the geriatricians, and it really makes a nice situation because they understand the importance of oral health. They'll send me patients, and they like to hear what I say. Next webinar will be available online. Okay. Had a patient come in recently who wasn't herself, almost like a fast onset dementia stroke. She has no family, so yeah, I guess we're out of time on that right now. Those are really difficult situations. I really, when somebody comes in by themselves, if there's no family members, then I think that just contacting government services, Health and Human the Department of Aging, because they have resources to make sure that that individual is taken care of. So I think that's probably the right thing if there's no family, that they are difficult situations. And yeah, those are tough. Again, I have the advantage that, I have resources that I can turn to, because if they're getting the medical care, I can go to a primary care physician or I can go to a social worker. Social workers are also really good too. If you have a relationship with a social worker, they just have so much information. They can answer all kinds of questions. Do you bill dental insurance? We do. And that is another thing that's changed. When I started years ago, a lot of patients had dental insurance. They worked for big companies like, General Electric and Delta and IBM, and they kept their dental benefits. They retired and they kept their dental benefits, and companies are not that generous anymore. So that's not happening, but there still are individuals. And we also have patients that are still working that have dental insurance. And we do see younger folks also. A lot of times the children will say, hey, can you treat me too? And so I'll treat them, as long as they're adults. I'll make exceptions and treat their children, who oftentimes are in their 60s anyway. So.
Excellent. Well, I think you got through all of them. And with that, we are right at time. Anyone wants to register for the next webinar, that is in the chat. Thank you, everyone, for joining. And of course, big thank you to you, Dr. Hendler, for all of your work in geriatric dentistry and for your presentation tonight. We did record the webinar, so we will send that out as well. That's it. I hope to see you all in a couple weeks for part 2. Have a great night, everyone.
Thanks, everybody. Good night.